Hello, everyone. So this is the last lecture on the GI, the second component or section of the recorded lectures in the GI and biliary system. So the colorectal cancer, so CRC, abbreviation for the colorectal cancer. Most cases occur after age 50, and there are two different types of colorectal cancer. The first one is called familial adenomatous polyposis, FAP. The other type of CRC is called HNPCC, which is the hereditary colorectal cancer syndrome, or Lynch syndrome, or hereditary non-polyposis colorectal cancer, or you can call it Lynch syndrome, LYNCH syndrome. So suspected hereditary non-polyposis colorectal cancer, which is the Lynch syndrome, it's suspected in a younger person with colon cancer and a family history of colon, ovarian, and endometrial cancer. So in terms of screening protocols or endeavors to screen the population or people at risk for CRC, to screen all average risk patients over 50 years of age with annual fecal occult blood test, FOBT, which is a guaiac test, and flexible sigmoidoscopy every 5 years or colonoscopy every 10 years. That's one of the best health promotion preventive measures and screening people for at risk for colorectal cancer. The symptoms depend on the site of the tumor and may include like change of bowel habits, melena, which is blood stool, dark colored or bright red blood, rectal bleeding, weight loss, fatigue, generalized weakness, vomiting, abdominal discomfort. All of these are signs and symptoms of colorectal cancer. The diagnosis, it can be diagnosed by a mass being palpated by the DRE, which is digital rectal exam, or detected by the FOBT, fecal occult blood test, guaiac test. Patient also will be anemic, so they will have iron deficiency anemia. And the disease most often metastasizes to the liver. Liver cancer will result as a secondary cancer from the primary cancer, which is the CRC. To confirm diagnoses, colonoscopy is the best tool, and biopsy, because at the same time we do colonoscopy, we can do a biopsy, and we can also treat and ligate and remove the polyps if there is any polyps. Those polyps, they are precursors, they are benign tumors, but they are also they can be precursors for a CRC. So in the future, these polyps do not even benign, they become cancerous, become malignant in the future. So that's why the colonoscopy, it confirms diagnosis of CRC, and also we can take biopsy and we can remove the polyps, which are the precursors for the colorectal cancer. The treatment of colorectal cancer, it's all the decisions of treatment or treatment decisions are influenced by the tumor size, stage, at diagnosis, at the onset of diagnosis. So the first surgical resection involves resection of the bowel segment with adjacent mesentery and regional lymph nodes. And usually stage 1 patients, they have an excellent prognosis with surgery alone. So stage 1 patients in stage 1 cancer, colorectal cancer, they benefit from the surgical intervention, surgical resection, which is, we call that hemicolectomy, the excision and surgical removal of the affected colon. That's called hemicolectomy. So patients stage 1, they have an excellent prognosis with surgery alone, about 90% survival at 5 years. And then with stage 2, 3, and 4, then we'll have adjuvant chemotherapy that is warranted for patients at stage 3 and above. So this is a scenario of a patient who was 61 years old, presented to the provider for a regular checkup. So which colorectal cancer screening, in terms of tests you will do, there are different tests can be done to screen patients for the CRC. So which test would be best for this patient to screen the patient for colorectal cancer? Well, colonoscopy, we said that colonoscopy is the best, which confirms diagnosis. So the patient should undergo screening colonoscopy, especially with his strongly positive family history of first degree relative developing colon cancer before age 50. So colonoscopy is the only test that can directly evaluate the entire colon and rectum. Most polyps can be removed completely. You can remove them during the procedure. Polyps completely can remove at the colonoscopy. And large lesions or masses can be directly biopsied. You can take biopsy if there is like a large lesion or mass. We can take biopsy from these lesions or masses. So doing the virtual colonoscopy and barium enema, that's combined with flexible sigmoidoscopy, all are good tests, but any positive findings from these tests would warrant further examination with colonoscopy. And the barium enema by itself or alone is insufficient for screening. Same thing for the fecal occult test. That is helpful as a screening tool, but would be inadequate alone in this patient who had a family history with cancer, especially colorectal cancer. Number 2, patient's family history is strongly suggestive of which of the following? Well, the patient satisfy criteria for the HNPCC, hereditary non-polyposis colorectal cancer syndrome or Lynch syndrome. He has 3 first-degree relatives with cancer of the colorectum, endometrium, small bowel, ureter, and renal pelvis. So the colorectal cancer or colorectal cancers involve at least 2 generations, and at least 1 case was diagnosed before age 50. So a 27-year-old female whose father has a colon resection for adenocarcinoma undergoes her first colonoscopy. The most appropriate next step in the management of this patient's disease, which are the following, So the answer would be A, which is total protocolectomy with ileal anal G pouch reconstruction. Now, the patient described has the familial adenomatous polyposis, FAP, and it's a rare autosomal dominant inherited form of CRC that result from what is called the germline mutation in the APC gene. So it has genetic predisposition. There's a specific gene that is responsible for this disease. And the disease is characterized by the presence of over 100 polyps in the large intestine. And other parts of the GI. All patients with the familial adenomatous polyposis, the FAP, will develop colorectal cancer if left untreated. So patients with the FAP, they can develop the colorectal cancer if left untreated. The average age of diagnosis is about 29, and an average of the development of the cancer is about 39. So once diagnosed, the most definitive treatment requires complete removal of the entire colon and rectum in a timely fashion. That's the only and the best appropriate treatment for the patient's surgical resection, hemicolectomy. So the surgical procedure of choice is the proctocolectomy with permanent ileostomy or creation of an ileoanal anastomosis. Anastomosis means we remove the affected part, the diseased part of the colon, and then we re-anastomose means re-suture both ends of the colon, kind of resume the continuity of the colon. So we will create ileoanal anastomosis with ileal reservoir, like a G pouch. That's the best choice for that age group. The abdominal perineal resection with sigmoid colectomy, it will leave a significant portion of colon in situ, subsequent risk to develop the colorectal cancer. So J-shaped configuration of ileoanal reservoir, that's the most popular procedure because it spares the rectal sphincter and eliminates the need for an ostomy. So there is no need for ostomy or colostomy or any type of ostomy for this patient because we can preserve the rectal sphincter with this procedure. Next question, the answer is C. So the patient appears to have the other type, which is HNPCC, which is the hereditary non-polyposis colorectal cancer, which is called E-Lynch syndrome, which is an autosomal dominant inheritance type of cancer. People who have this predisposition or this type of disease, they are predisposed to colorectal cancer, and it involves at least 2 generations. So it is recommended that HNPCC or Lynch family members undergo screening colonoscopy every 2 years, beginning at age 25. Because the colon cancers in the Lynch syndrome, often it involves the proximal colon. So the flexible sigmoidoscopy would be insufficient tool for screening the at-risk bowel. Next question, the answer is AST and ELP, alkaline phosphatase, and the EST. The alkaline phosphatase is an enzyme produced in the bone and liver, and the EST is an enzyme produced in the heart and liver. Both are elevated when the liver cancer is present. And the EST supposed to be between 8 up to 38, but in this patient is extremely higher than 38, so it's about 76. And the ALP, alkaline phosphatase, is usually between 42 up to 136. And it's extremely high in this patient, 500. So it's an indication that there is a liver cancer that is present here. The elevated BUN and creatinine could indicate kidney renal involvement. Decreased albumin and calcium could be related to the kidney or to poor nutrition. Elevated white blood cells and neutrophil would indicate an acute inflammatory or infectious process. The answer to this question is 3, which is document these findings. So the nurse should document the findings. The absence of stool is expected. Absence of stool is expected 24 hours post-surgery. Laxative is unnecessary. The absence of stool is unexpected, so there is no need to call the surgeon. And at left side, lying position will not produce stool if peristalsis has not yet returned. The answer 3 is prevent the return of colon cancer. Now, aspirin, equitrin, 325 milligrams, not the 81 milligrams. Equitrin or aspirin, 325 milligrams, taken daily, has been shown to decrease the risk of recurrence of colorectal cancer. So the answer to this question is 3, which is the bowel um, will be cleansed before surgery with laxative, enema, or whole gut lavage, which is cleansing the GI tract and preparing the GI tract. The bowel is cleaned preoperatively. So for the surgery, pre-op, that bowel should be cleaned and cleansed completely from any content to reduce the risk of peritoneal contamination by bowel content during surgery. And since this is a select all apply, 1 is also a correct answer. So the correct answer is 1, 3, 4, and 5. So all but 2. So 1, to explain number 1, the abdominal perineal resection removes the sigmoid colon, rectum, and anus. As a result, the client will have a permanent colostomy. So that's why it says the interstomal nurse will be visiting the client prior to surgery in anticipation. After surgery, the patient will have removal or resection, surgical resection of the sigmoid colon, rectum, and anus. So as a result, the patient will have a permanent colostomy. So the interstomal nurse will identify and mark an appropriate stoma location after considering the client's skin folds, clothing preferences, and the level of colostomy. And we did explain number 3 and number 4. The antibiotics are prescribed to be given and administered pre-op for surgery to reduce the risk of peritoneal contamination by bowel contents during surgery. So prophylactically, you can prevent infections. And number 5, post-op, the client with the abdominal perineal resection is at risk for the sexual dysfunction and drink incontinence as a result of nerve damage. So that has to be discussed with the client prior to surgery by the surgeon or a member of the surgical team. So a member of the surgical team or surgeon should discuss that and explore patient's options about that problem. And the next question, the answer is 3, that assess the perineal dressing for drainage. The perineal incision, the surgical incision, must be examined frequently to assess for any drainage and the need for dressing changes. After bowel surgery, a temporary ileus is expected, so the client would be NPO, nothing by mouth initially. There would be there would not be stool expected or coming from the colostomy until the bowel peristalsis returns. So we're not expecting or anticipating any stool that is coming from the colostomy until the bowel peristalsis resumed or returns. Now, the client's physiological needs in the early post-op period take preference over the integration of the body image or change into the client self concept. So the physiologic takes preference over um, the body image changes. Next question, the answer is B, which is the supine anorectic X-ray of the abdomen. So this patient presents with the classic symptoms of a bowel obstruction. The diagnosis is often made by a thorough history and physical examination. Following the initial evaluation, an acute abdominal X-ray series should be obtained, which includes supine and erect views of the abdomen. The diagnosis is confirmed with the presence of dilated loops of bowel with the presence of air-filled fluid. There will be loops that are air-filled, um, and these plain films may also suggest the location of the obstruction. We can indicate or be able to view and identify it as a small versus large intestine. So these plain films, they also suggest the location of the obstruction, small versus large intestine. The abdominal ultrasonography has a limited role in the diagnosis or management of the intestinal obstruction. Serum electrolyte determination helps in identifying the electrolyte disturbances, but have taken that occurred or taken place. The fluid loss needs to be corrected with rehydration. So I have to give fluids, rehydration, fluid replacement. We have to give fluids to correct the fluid loss. And then nasogastric suction, it would help in decreasing abdominal distension, so we can decompress the GI tract. Upper GI endoscopy would increase distension, and it's contraindicated. Antiemetics should not be given until a definitive diagnosis is made, and then only if indicated. Pro-motility agents. These pro-motility agents, they have little to no role in the management of patients with bowel obstruction. And some would even consider it as to be contraindicated. And these pro-motility medications would be like a metoclopramide, for example. Next question, the answer is D, diverticulitis. So an annular constricting lesion with overhanging edges is typical of annular carcinoma of the colon. So that I'm sorry, I said the answer is carcinoma of the colon. So so we said that the annular constricting, so the carcinoma of the colon is the diagnosis for this patient. because there is an annular constricting lesion with overhanging edges, and that is typical of what is called annular carcinoma of the colon. Mechanical small bowel obstruction results in multiple air-filled levels in distended small bowel loops. But in the diverticulitis, there is an extravasation of barium outside the lumen of the colon. Yeah, this picture might not be a good one, but it's just there you can diagnose and identify the changes in the GI, and you can tell if that's carcinoma of the colon, if that's diverticulitis, intussusception, which is like telescoping of the small intestine or large intestine into each other. And the answer to this one is that the nurse should obtain a double lumen NG, which is number 2, which is a Salem sump tube. So that's the double lumen NG tube with an air vent for the continuous suction. The pigtail, which is an air vent, helps to keep the tube away from the stomach, wall, so that it doesn't result in damaging the stomach wall or mucous membrane. So this is called Salem sump tube. It's a double lumen NG tube with an air vent for continuous suctioning. So this air vent or pigtail helps to keep the tube away from the stomach wall, so it will so that it is not damaged. Next question, the answer is 3, which is decreased lung sounds in both lung spaces. Now, decreased lung sounds are the most concerning finding because it can be life-threatening. Massive distension can impair function of the diaphragm, which in turn leads to atelectasis and compromised respiratory function. Next topic, which is cholecystitis and cholecystectomy. So the gallstones can be symptomatic or asymptomatic, and they are usually formed as cholesterol stones, and they can also result in cholecystitis, which is inflammation of the gallbladder, or cholangitis, which is the inflammation of the colon bile duct. So in trauma patients or burn patients or patients on a TPN, total parenteral nutrition, the acute cholecystitis may occur in the absence of stones, which is called ecalculous cholecystitis. So patients with trauma, burn injuries, patients who receive a TPN, they can develop ecalculous cholecystitis, which is cholecystitis in the absence of stones. Symptoms, right upper quadrant pain, fever, jaundice. Most patients with gallstones are asymptomatic. About 80% of the patients with cholecystitis, they are asymptomatic, no symptoms, no apparent clinical manifestations associated with or present during the disease process. May also be present as like biliary colic, right upper, which is biliary colic, which is characterized by episodes of right upper quadrant pain or epigastric pain that may radiate to the right shoulder. And pain is usually postprandial, after eating, after meals, postprandial after meals, and lasts the pain in terms of timing. The pain would last for about 30 minutes, and it's usually accompanied by the vomiting, and is associated with, usually it will elicit the pain episode and the other symptoms of the cholecystitis. That is associated with fatty food intolerance. And if the patient develops cholangitis, that will result in the fever, jaundice, and persistent right upper quadrant pain. There are risk factors for cholecystitis. We used to have them in the EG textbook as the 4 Fs. Now it's 5 Fs. Fat, female, 40 in terms of age, fair, fertile. The diagnoses, the lab values or labs reveal leukocytosis, elevated white blood cells, and elevated liver function tests, LFTs. The ultrasound is about 85 to 90% sensitive for gallbladder stones and cholecystitis. Because the gallbladder wall is thick, so the thickened gallbladder wall and the that's why we have 85 to 90% sensitivity for the test, given that the gallbladder wall is thick, and that's make it less sensitive in terms of or specific finding. So these pictures, we have A and we have B. A, which is the cholelithiasis, which is stones in the gallbladder. So this is an ultrasound image of the gallbladder, shows a gallstone in which you see the arrows with posterior shadowing. B, which is the acute cholecystitis, the ultrasound image shows a gallstone, which is the red arrow, and a thickened gallbladder wall, the arrowheads. And there is also the cholecystatic fluid, which is the white arrow fluid. So the acute cholecystitis treatment for the acute cholecystitis is the IV antibiotics. Generally, the third generation cephalosporins plus the metronidazole. In severe cases, we give fluids, IV fluids, electrolyte repletion, which is to replenish and to replace and correct the electrolyte imbalances. The yearly cholecystectomy within 72 hours with an intraoperative cholangiogram to look for common bile duct stones. So during the cholecystectomy, we can also, during the surgery, we can also look for and find any other stones in the biliary tree, like in the common bile duct or cystic duct or hepatic duct. So any stone left, it can result in obstruction and biliary obstruction. So for patients who are high-risk surgical candidates, elective surgery may be appropriate if the clinical condition allows. So for patients who are not candidate for surgery, we can consider a percutaneous biliary drain. So as we said that the classic manifestations of the acute cholelithiasis or cholecystitis, in this case cholecystitis, which is due to the presence of the stones in the gallbladder, is the severe and steady epigastric or right upper quadrant pain that radiates to the right scapula or shoulder. And it's a sudden onset. It may last 1 to 3 hours, up to 3 hours. And that usually occurs after a high fat meal. Other symptoms may include nausea, vomiting, or heartburn, um, and fever and chills will occur with acute cholecystitis. So this is a case study of a 45-year-old woman, mother of 4 children, and the answer to this question is A, which is an acute cholecystitis. So as we said that the acute cholecystitis is much more common in women than men. In addition to the gender, the development of the gallstones can also be affected by age, weight, family history, and pregnancy. Gallstones are often remain asymptomatic, but they can cause symptoms when these stones result in an obstruction of the cystic duct. The result of this obstruction is biliary colic, which is usually experienced as an epigastric pain radiating to the back and can be associated with nausea and vomiting. The presence of tenderness on to palpation in the right upper quadrant, fever, leukocytosis, which is elevated white blood cells, would suggest the acute cholecystitis, which is a complication of gallstones. Answer to this question is B, ultrasonography of the upper abdomen. In a patient suspected of having complications of gallstone, the best test for evaluation is ultrasonography. Ultrasonography is highly sensitive in detecting gallstones and also provides details about the thickness of the gallbladder wall. So you can get more info and like results and data about the thickness of the gallbladder wall, the presence of any precholcystic fluid, and also the presence or absence of any tenderness over the gallbladder during the examination. The two-way retingogram of the abdomen is much less sensitive, detecting only 20% of gallstones. A CT of the abdomen with IV and PO contrast can be sensitive in detecting the inflammatory changes that are associated with acute cholecystitis, but it's much more expensive and time consuming when compared to the ultrasound. The HIDA test. Although the HIDA test is sensitive and specific in the right setting, it is generally reserved for more complicated cases where the diagnosis is unclear. Failure to visualize the gallbladder with HIDA scan in 1 hour indicates either partial or complete cystic duct obstruction and confirms the diagnosis of acute cholecystitis. However, this should not be the first line test in evaluating the patient for acute cholecystitis. So it should be more saved for complicated scenarios. MRCP, and we have ERCP, endoscopic retrograde cholangiopancreatography, or magnetic retrograde cholangiopancreatography. ERCP and MRCP, these are two most important diagnostic tests for the hepatic disease, especially with cholecystitis. So the MRCP can be very useful in evaluating the biliary tree. When we say biliary tree, means cystic duct, bile duct, communal bile duct, and the hepatic duct. So we can evaluate all these three biliary ducts, we call it biliary tree, and the presence of any cholelithiasis, like stones within these ducts, in the patient who have or been diagnosed with cholecystitis, especially if they have elevated bilirubin, because one of the signs of the elevated bile duct obstruction is the elevated bilirubin. Bilirubin is not being released into the GI tract, it will be reabsorbed and be present, or be in the plasma or blood, and then reabsorbed, and then in the under the skin sclera. So there is an elevated bilirubin level in the blood. So this MRCP, as we said, is very useful in evaluating the biliary tree and presence of the cholelithiasis, stones in the biliary tree in a patient with cholecystitis and elevated bilirubin, but it doesn't have a role in diagnosis of acute cholecystitis. So this will be very effective in diagnosing patients with biliary obstruction, stones obstructing the biliary tree. And the HIDA test, it's a scan in which patients will be given an IV injection of what is called TC99M, and they will be patient is positioned under the camera to record distribution of the tracer in the liver, in the biliary tree, in the gallbladder, and proximal small intestine. And this test is used to identify obstructions of the bile duct with either gallstones or lithiasis or with tumors. So our responsibility during the HIDA test is to tell patient that substance, this substance, the IV, the TC99M, to be ingested contains only tracers or small amounts of radioactivity and will pose little to no danger. So the negative HIDA test indicates that there is no obstruction in the gallbladder. False. I mean, false positive are common. False positive results are common, but the negative HIDA test indicates that there is no obstruction in the gallbladder. Patient evaluated for left-sided abdominal pain and undergoes CT scan of the abdomen that shows renal calculi. So the answer is E, which is sickle cell anemia. The incidental finding is a gallstone within a gallbladder without evidence for inflammation. For most patients with asymptomatic cholecystitis, so cholelithiasis, which is we said E calculus, we call that E calculus cholelithiasis. So it's asymptomatic cholelithiasis. So for most patients with asymptomatic cholelithiasis, cholecystectomy is not routinely performed. Only 20 up to 30% of these patients will develop symptoms within 20 years. And about 1 to 2% only per year will develop serious symptoms or complications from these gallstones. However, certain patients are at great risk to develop complications and should be considered for elective cholecystectomy. This population includes patients with stones larger than 2.5 centimeters in size. These stones are larger than 2.5 centimeters in size, since they will be at high risk for bile obstruction. So in patients with sickle cell disease, acute cholecystitis can induce a sickle crisis, which can complicate surgery and as such should undergo elective cholecystectomy. So the answer to this question, the first one is A, clay-colored stool. And this is one of the most common concepts in understanding the biliary obstruction. White or clay-colored stool and dark urine are two main manifestations of bile obstruction, in addition to jaundice as well. So with complete obstructive jaundice, the stools are clay-colored. Clay, whitish colored, the stool, the urine is dark. Second question, the answer is D. Laparoscopic cholecystectomy is the treatment of choice for symptomatic cholelithiasis. Number 3, the answer is B. Reporting any bile-colored drainage or pus from any incision. So there are some discharge instructions that are taught to the patient. We have to educate the patient about these instructions and the caregiver, if that applies to the patient or the case scenario, after the laparoscopic cholecystectomy, lap chole, we call it, lap chole or laparoscopic cholecystectomy. So laparoscopic cholecystectomy will be exactly this figure explains the lap chole or illustrates the laparoscopic cholecystectomy. 3 small holes for incisions, one for the tools, and one and the other hole for the camera, and the third hole for the injection of the or to infuse or inject the CO2, the carbon dioxide, so they can easily visualize and they can see the internal organs and they can operate on the patient through the screen, like what through the screen or the monitor. So we said the answer for 3 is B, and these are the instructions to remove the bandage on the puncture site the day after surgery, and then patient can shower. And we have to call or notify the surgeon if the patient developed any of these symptoms, like redness, swelling, the drainage becomes like bicolor drainage or pus from the incision, severe abdominal pain, nausea, vomiting, fever, chills. Um, and then patient can gradually resume normal activities, and they can return to work within like 1 week of surgery, post-op, and resume a usual diet, but has to be low-fat diet for several weeks after surgery. Answer for number 1 will be ice cream, brownie with nuts, broccoli with cheese sauce, potatoes, gravy, deviled egg, and mayonnaise. So food high in fat, such as the ice cream, brownies, and cheese sauce, gravy, and mayonnaise, that could precipitate an attack of cholecystitis and should be avoided. Foods not high in fat, such as fruits and turkey, are usually better tolerated. Now, second question, clay-colored stool, elevated white blood cells, and yellow sclera. These manifestations indicate the bile is not being secreted into the small intestine due to the biliary obstruction. The dark urine, elevated serum cholesterol levels are other manifestations of the biliary obstruction. Number 3, we would instruct the client to clamp the T-tube 1 to 2 hours before and after meals prior to removal to assess tolerance to food post-op. So after the surgery, we would instruct the patient to clamp the tube, the T-tube, 1 to 2 hours before and after meals, prior to removal, before we completely remove the T-tube. So while the T-tube is in place, so we can assess the tolerance to food post-op. Also, we instruct the client to avoid heavy lifting to prevent evisceration of the incision, and to empty the drainage bag attached to the T-tube every 8 hours to prevent the reflux back into the bile duct. The client should take showers rather than baths due to the increased risk for infection from entry of microorganisms into the wound. And we also instruct the client to maintain the flow of bile drainage by gravity. So not to place the drainage system at or above the level of the gallbladder, which always has to be below the level of the gallbladder, so it can drain by gravity. But due to the risk of infection from reflux of drainage from the drainage tube into the wound itself. So this concludes our lecture today.